Now we will move on to see what is the incidence of occipitoposterior. As I mentioned earlier, it's about 10 to 13% of all vertex presentation. Most of the time during labor, there will be a spontaneous anterior rotation. ROP is more common than LOP because on the left side sigmoid colon and dextrorotation of the uterus prevents the fetus to take a left occipitoposterior. Now we will see to the etiological factors associated with occipitoposterior. Exact cause is unknown, but the predisposing factors are: one is with the pelvic shape, that is android or anthropoid pelvis is more commonly favoring occipitoposterior. Similarly, contracted pelvis, when the diameters of the pelvis are less than the normal, chances are more in favor of occipitoposterior. Various other causes are such as the uterine conditions, which may be placenta low-lying, or any congenital malformations of the uterus, or any fibroid or tumors of the uterus. It can also be due to preterm, that is, as the fetus tends to move often, chances are there to occupy occipitoposterior, and also with multigravida because of lax uterine muscle. There are three types of occipitoposterior. It can be right occipitoposterior when the occiput lies on the right sacroiliac joint, or a left occipitoposterior, or a direct occipitoposterior. Direct occipitoposterior is nothing but occiput lies on the sacrum. The signs and symptoms of occipitoposterior are: one is subumbilical flattening, where you can beautifully look with occipitoanterior and occipitoposterior the difference between the subumbilical flattening. Back is near the flanks, where you can identify it in the figure. Limbs are felt easily and fetal heart rate is most audible at the flanks. Diagnosis may be through signs and symptoms, and also through an vaginal examination, wherein you may identify elongated bag of membrane which is likely to rupture during examination, or a sagittal suture may occupy sometimes oblique diameter or sometimes a transverse diameter of the pelvis. Posterior fontanelle may be felt near to the sacroiliac joint, and anterior fontanelles are felt more easily because of deflection of head. Ultrasonography may also help to know the descent, attitude of the head and relation to pelvic walls.